Hey Josh, are you able to screen share? See your screen up. Just want to make sure it works.
Was trying to play around with it earlier. All
Okay.
right, can you see that?
Yes.
I'm on Google Slides, so it might look a little different, but
I mean, I can see the title there, so it looks like it's good to go. Yeah.
okay,
So whenever you want.
cool. Let's wait maybe one more minute and then I'll get started.
Sounds great.
Okay, I'll go ahead and get started. Um, Hello, everyone. My name is Josh. I am one of the sleep fellows, as most of you know. And today I'll be talking about OSA primarily, but sleep disorder breathing and stroke, some of the good, the bad, and the potentially exciting. Took me a while to kind of narrow down a topic for grand rounds today. But one thing that did help was that we are actually in Stroke Awareness Month, which is May. So happy Stroke Awareness Month, I suppose. I don't have any disclosures to mention. And this is the agenda for today's talk. I'd like to just review what stroke is, just kind of remember the different types and some of the statistics with stroke. And then we'll dive into how sleep disorder breathing and stroke and this bi-directional relationship between the two. We'll look at some of the older studies or some of even the seminal studies for obstructive sleep apnea, and then also some of the newer studies that are out right now that are kind of looking into the different relationship with stroke and obstructive sleep apnea. We'll briefly talk about treatments. I'd like to talk about, or at least mention, some post-stroke rehabilitation stuff. And then, if you will, all with me, kind of jump into my head and brainstorm or fantasize or how we want to look at this. But I have some questions at the end that this is where the exciting part comes in, because I think sleep medicine is at a place in time specifically for the stroke population that's exciting as far as what we're investigating. So we'll kind of dive into that as well. So to start, stroke remains the second leading cause of death worldwide. It has fallen a little bit in the United States, and is now fifth leading cause of death. And this is behind heart disease, cancer, unintentional accidents, and COVID. However, maybe more importantly, it's the first leading cause of disability worldwide. So if you do survive a stroke, this is likely going to be changing your life. The lifetime global risk of stroke for adults is approximately 25%. In the United States, the annual incidence of stroke is almost 800,000. And most of these are new strokes. And then it's an expensive process as well between hospitalization and overall stroke care with medicines. I found a figure that shows that Americans spend on average over $45 billion each year in regards to stroke care. You may have heard of the term the stroke belt. This picture is actually highlighting stroke deaths, but I think it does a good job of still highlighting geographically what's kind of termed as the stroke belt, which is primarily the kind of southern or southeastern states there, and the darker purple are highlighting the higher death rates in the United States. So if that doesn't depress you, I found a quote from Dr. Jones Jr. He's actually the current editor of Continuum, which is, I think most neurologists probably know this, but it's a journal kind of designated more for trainees. But in the most recent cardiovascular journal, and I'll just read this to you, to study stroke is to understand loss. The sudden focal disappearance that characterizes cerebral vascular disease immediately changes a person's life. Lingering stroke deficits may tip over dominoes that include jobs, hobbies, mobility, social engagements, and personal independence. We collectively lose lives, loved ones, and leaders to stroke. So very common, very kind of dramatic health problem. And there are some sleep consequences with this as well that we'll talk about today. So let's back up and talk about what is stroke. So as most of you probably remember, there's a couple different types of stroke, and they're kind of broadly kind of diverted into something called ischemic and hemorrhagic or bleeding strokes. And the vast majority of these are ischemic. This is where like the blood vessel actually gets clogged and the tissue that artery is perfusing starts to die. So about 85% of all strokes are ischemic strokes. And in this figure, the bottom squares, those 5 squares there, are highlighting different etiologies of ischemic strokes. And this is actually stems from something called the TOAST criteria. And this is the major goal after someone's admitted with an acute stroke is to figure out why they had the stroke. And so we use imaging and lab data and cardiac monitoring and things of that nature to help us determine what causes the stroke. And that, as I mentioned, is actually called the TOAST criteria. There's also something called TIA. What is a TIA? It's a stroke warning sign, or I've also heard this called a precursor to an ischemic stroke. And these are still vascular events. It's essentially a stroke where the clot has been removed and the blood flow has continued on where the tissue hasn't died yet. But in that moment, there is signs and symptoms of stroke, and they can look and be as dramatic as an actual stroke. Usually the symptoms resolve within a day, and more commonly even quicker than that, usually within an hour. The term TIA used to be just that, like, hey, if you have symptoms and they resolve within 24 hours, we'll call that a TIA. But as we're finding out, especially with more imaging modalities and better MRIs, there are some small strokes where their symptoms do resolve within that time frame. But if it does show any fingerprints on the MRI showing any sort of damage, we would call that a stroke. But if you came in with signs and symptoms of stroke that have resolved and your MRI is clean, that's what we call a TIA. And as we'll see, that this group of people still are at risk for obstructive sleep apnea, even though we haven't seen the damage to the brain like we would with a stroke. So here's 2 CT scans. The one on the left is an ischemic stroke or an ischemic infarct. And I'm not sure if you can actually see my mouse at all or not, but I'm highlighting here some loss of gray-white. This is a large left MCA stroke seen on the CT scan, and we're comparing that over here to this other one, which is a bleeding type of stroke. You can see that the blood is actually here. It's very kind of dramatic on a CT scan. This is why they're so utilized in the emergency rooms. But from an imaging standpoint, this is kind of how these different strokes may look on imaging as we kind of differentiate what type of stroke and where the etiology may have come from. So now let's dive into obstructive sleep apnea. And as you can see on the top right corner, I have a picture of, presumably a person who's trying to bring in air, and it looks like the airflow is maybe vibrating or maybe snoring. That's supposed to symbolize obstructive sleep apnea. And then the arrow kind of pointing toward stroke. And I think as we talk about consequences of obstructive sleep apnea, we do a really good job with this with our patients. But I want to take some time and kind of revisit some of this data, so we're kind of aware of it, especially for myself and the other fellows going forward. Kind of revisit some of these older studies. But even taking a further step back away from the vascular risk factors, I found this picture online, which I felt like was a good representation to show that obstructive sleep apnea can affect almost the entire body. So as I mentioned, the red boxes are more of the cardiovascular risk factors that we, I think, at least for myself, think about more commonly. But we know it has an effect on metabolism and insulin resistance for diabetics. And kind of with that, obesity as well. We know it affects GERD, erectile dysfunction, nocturia, your mood, your sleepiness, all this kind of stuff. So I thought this was actually a good picture, kind of taking a bird's eye view of the consequences of stroke. But for today's talks, specifically, since we're talking about stroke, we're going to kind of hone in on those vascular risk factors. So here's some of the seminal or older studies. I think most of us will at least recognize these pictures. But Telkin back in the 70s was kind of the first person to kind of highlight that classic cyclical changes in both blood pressure and heart rate that are kind of linked with those obstructive events during the night, during sleep. And Summers's paper kind of expanded on that, where once again, we see the obstructive hypopneas here. We see the rise in blood pressure. And then he also used a micro catheter or a micro electrode. This SNA depiction is actually coming from efferent autonomic nerves. And so the sympathetic nerves rather. So the sympathetic tone actually increases as the obstructive event is occurring. And then after the obstruction is relieved, the sympathetic tone goes down. And then this even had a cyclical relationship. So kind of cool depictions of kind of pioneer papers depicting what OSA kind of clinically looks like in the acute setting, how the changes of blood pressure, heart rate, and even that sympathetic tone happen. So those vascular risk factors that we usually talk about are things like hypertension, atrial fibrillation, atherosclerosis. And so let's quick dive into each one of these and talk about why OSA can affect those individually. So here's two studies looking at hypertension back in the 2000s. We got the Sleep Heart Health Study and the Wisconsin Sleep Cohort Study. In the first one, they had over 6,000 patients, but they were able to show an odds ratio that was 1.37 when they compared severe sleep apnea to people without sleep apnea. In the Wisconsin Sleep Cohort Study, they actually had a nice graph, I felt like, that kind of showed actually a dose response to your severity of sleep apnea and the effect it may have on hypertension.
And Josh, I have a quick question. If I recall, these are all with hypopneas with the 4% desats, correct?
Oh,
I'm pretty sure.
I think so. To be honest, I don't I don't want to misspeak, but I don't know for sure. But I think you're right. I think the older studies were the more significant ones, but I can kind of follow up on that. And then we have atrial fibrillation here on the left in this study by Gamey et al. OSA, even mild OSA or anything greater, did show a strong prediction for developing atrial fibrillation. So once again, a nice graph kind of showing that over time, there is a risk for all of us to develop atrial fibrillation, but that risk continues to go up if you have obstructive sleep apnea. Atherosclerosis, this was kind of a cool study where they actually measured the carotid wall, the intima media thickness. And in patients with obstructive sleep apnea, it was significantly thicker. Kind of looking at the data here, 1.4 versus 0.9 millimeter thickness when obstructive sleep apnea patients were compared to non-obstructive sleep apnea patients. So these are kind of those vascular risk factors that we talk to our patients about and say, hey, if you have sleep apnea, we should treat it because these things can continue to get worse if we leave this untreated. But the question kind of remained, hey, is obstructive sleep apnea just causing these problems, and this is why? Because all of these are the same risk factors for stroke. Or is obstructive sleep apnea an independent risk factor for stroke? And that question was actually investigated by Yagi et al. This was an observational cohort study back in 2005. And indeed, that bottom line there, they had over 1,000 patients, but after adjusting for confounding factors, including all those vascular risk factors that we talked about, there was still a hazard ratio of almost 2, even with getting rid of those confounding variables there. Which is interesting. So once again, I think we do a pretty good job of detailing this to the patient and giving them some of this data. But now hopefully we have some kind of basis on where this comes from. But why might this be? Why is OSA a risk factor for stroke? And it seems to be a little chaotic, to be honest, as I was reading about this. It seems to be like multiple mechanisms, and I think we're a little unsure exactly what component of what is maybe kind of leading the cause of this. But here are some of the mechanisms that's been proposed. That was kind of highlighted in this Barone study. But hypoxemia burden, sympathetic activation, the emergence of arrhythmias, as we mentioned, things like atrial fibrillation, seems to affect the coagulation within the body, and kind of with that too, endothelial dysfunction or damage to the blood vessel walls. There seems to be an effect on inflammation. These are things like CRP, TNF, IL-6, and VEGF. Metabolic factors like insulin resistance. And even that dramatic change of pressure during obstructive events, when they're recurring over and over again, it affects the different pressures of the heart, which can reopen the PFO, which does increase people's risk of having strokes as well, even getting that right to left shunting occurring with obstructive sleep apnea. So I felt like this picture by Portella's group in their paper showed a little bit of that chaos. When you look at this, the first thing I thought of, like, oh my gosh, there's like arrows going everywhere. But if we kind of start from the top and kind of work our way down, everything kind of funnels into this stroke kind of in the bottom middle there. So there's some risk factors that, we can't do anything about: your sex, your race. And as we come down, it kind of forks into the apneic or snoring kind of category, and what that might, what kind of consequences might come from that. Versus the other side is the hypoxemia, and with that low oxygen, what kind of stress to the body that might involve. And you can kind of see here, increasing that sympathetic activation, leading to things like arrhythmias, increasing the systemic blood pressure. This all kind of factors in together, once again, funneling into this consequence of stroke. So how do we avoid this? We prescribe a lot of CPAP. We also prescribe a lot of alternative therapies. These pictures are not an exhaustive list of treatments for sleep apnea. But or at least as I usually counsel my patients, I say, CPAP is the gold standard therapy to start with. I feel like I can have the most kind of control of your sleep apnea. You can review your data, see how you're doing with it. And then if we can't tolerate it, there are these alternative therapies. And I feel like they're going to continue to come out with more and more of these that we'll have to be kind of aware of as time goes on. And the idea is that we're reducing the risk of developing those cardiac or cardiovascular complications, including stroke, right? However, this editorial piece was actually thrown around in our fellows group, in our WhatsApp group, and I thought I'd at least bring it up here and talk about it because I think it is relevant. That does CPAP even help? Do we actually oversell this idea of what CPAP can actually do? So I'll let you read that kind of notation from the author and their kind of final thoughts of this paper. And they weren't specifically talking just about the stroke or just the cardiovascular risk, but also things like heart failure. But I feel like this colorful language is, something to at least look at. But I wanted to also look at it and say, hey, is there any basis for this? Why is this there? Why are we having these people commenting on CPAP? I need to answer this question for myself. So in kind of investigating this, this other study by Bolus's group in 2020 tried to look at the different studies with stroke patients and sleep apnea and treatments to look at their overall outcomes. And so what they found was in the majority of these studies, they did find some non-vascular improvements with the treatment of sleep apnea. So I've kind of highlighted some here in the green boxes. These are things like, improved depression, improved functional outcomes. The NIHSS is an NIH stroke scale, which is a clinical assessment usually done to stroke patients, something we do in the emergency room or even during stroke follow-ups to kind of have a numeric value on how well things are going. But some of these did find that their stroke scale actually improved with use of CPAP. But if we look at more of the cardiovascular outcomes that were looked at, most of these that actually looked at that indication did not find an actual impact on vascular events. And before I jump into this, I want to just kind of leave this out there to you all and say, what do you see, or what questions or what concerns do you have when you look at this table in the setting of why there has been no improvement in cardiovascular risks? Like, do you have any issues with how some of these studies were done?
Josh, I know you commented on this when we shared the article. Yeah, obviously the adherence is not as we want it to be. On an average, I think it's like 3 hours or so in all these studies. Yep.
Yeah, thanks, Anusha. Yeah, that to me is kind of the glaring thing. I think if I'm kind of nitpicking, I would say some of these other studies have low ends. We're dealing with 50 patients, 40 patients, 60 patients. We don't have like a ton of big trials looking at this. The one in 2016 did have 2,700 patients, and 1,300 of them did have stroke. But if we look, they didn't start CPAP for greater than 90 days. So maybe that was a reason why we didn't see that. And the adherence in that study was a little over 3 hours. So this to me is like a huge, like, what are we doing kind of moment when it comes to answering this question? Because for a lot of these studies, insurance would have pulled their equipment. They're not even meeting the kind of gold standard, or not gold standard, but the criteria that insurance has put out for labeling them as compliant. Yet we're using that same kind of marker as, is CPAP going to be helpful here? One thing I was kind of, once again, brainstorming on, of maybe one thing we could look at was something maybe like, what if we did like a CPAP efficiency? What if we looked at patients and said, hey, I only sleep 5 hours a night, but I use my CPAP for all of that 5 hours. That's probably good compared to someone who sleeps 10 hours and only slept 5 hours with their CPAP. That's only 50% of that. I would assume that the risk once they remove the machine throws their body back into that stressful situation. So I feel like we have some room to improve some of our studies going forward in both the adherence and maybe the description of what we actually look at for CPAP usage. Okay, so now let's say our patient that we've been trying to prevent having a stroke actually had a stroke. So you can see my depictions at the top here have actually flip-flop. Now let's look at how stroke actually impacts obstructive sleep apnea or sleep disorder breathing. So breathing changes after stroke have been noticed since the 1800s. And Seiler and his group, kind of most recently here in 2019, actually showed us that sleep disorder breathing is very common after stroke. 71% of patients had some degree of sleep apnea after their stroke, or TIA, which is crazy. It's like a huge percentage. Para's group back in 2000 looked at a couple different mechanisms and also locations of the brain and time frame of things, and their results showed that the frequency and severity was kind of irregardless of where their stroke location was. which I think for most of us, at least when I came in, I would say, oh, it had to be in the brainstem. Like if the brainstem was hit, that's probably where you're going to see sleep apnea, not so much the other areas. But their study didn't show that actually. They did notice that central apneas were more common in the acute setting and did get better, but they were expecting something similar with obstructive sleep apnea. However, that didn't happen. So the obstructive events persisted, even though the central apneas did improve with time. Once again, the Seiler group later on in 2019 did show that kind of irregardless of time, that sleep disorder breathing does persist after a stroke. And they actually kind of showed this using as a meta-analysis, looking at different types of evaluations for sleep apnea, and I'll get into that more in a second. But then most recently in 2021, we have a little different picture actually. So Lou's group actually showed with another meta-analysis that there actually might be some differences in location, stroke etiology, subtypes of stroke, and even the phase of stroke or the time frame of stroke. So I'd like to kind of briefly look at some of this data here. So this is the older study by Para that I mentioned. Their overall, this is just a snapshot of some of their data regarding the AHI and the time frame of stroke. And as I mentioned previously, they did show that there was a reduction in overall AHI and the central apnea index. But I think that they were wondering, hey, is sleep disorder breathing in general, including obstructive sleep apnea, improve with time? Like the insult happened, and as the brain heals, will that also get better? And they did not see that with obstructive events. Seiler's group, this is the one that the meta-analysis that showed how prevalent sleep apnea is following stroke. So you can see here an AHI greater than 5 is at that 71%. And when we look at severe sleep apnea, almost a third of patients after having stroke are in the severe category. And they also showed that it kind of irregardless of the time frame of looking at stroke, as they kind of differentiated the acute stroke within a month, the subacute period within the first 1 to 3 months, and then that chronic period, that sleep apnea does persist. And as I mentioned before, they did look at multiple studies, including different ways that these studies evaluated for obstructive sleep apnea. Even 10% of the studies they looked at actually used like an AutoPAP to kind of help determine some of this as well, which I thought was interesting. And then lastly, this is that most recent one that I mentioned in 2021, Lou's group. This is really interesting and kind of, I think, muddies the water even a little bit more, or maybe adds more questions to kind of evaluate later on. But they looked at 10 studies, which in total had almost 1,500 patients that actually mentioned the different classifications through the TOAST classification, and actually showed that there appears to be a greater incidence of sleep apnea or prevalence of sleep apnea with cardioembolic strokes compared to the other stroke etiologies. In 7 studies, a little over 500 patients, there seemed to be a predilection for supratentorial location. So as I mentioned before, my gut was that it must be more in the brainstem, but they're actually showing that the data shows that it might be more common in supratentorial strokes compared to the infratentorial strokes. And then there may be also a higher prevalence of sleep apnea with bleeding strokes or hemorrhagic strokes compared to ischemic strokes. Okay, so the whole point of inpatient care is basically to stabilize the patient after we've determined if there are any sort of acute interventions we can do to try to salvage their brain. And then they get assessments by multiple people in the hospital. And make sure that there's no atrial fibrillation or cardiology input, make sure there's no infections, things of that nature. But then ultimately we need to get them to rehab because they need to start improving. And so the next step with this is stroke rehabilitation. And this comes from one of the Continuum articles in the Cerebral Vascular manual. But I liked how this kind of highlighted the differences of this physical rehab and the different improvements that you might see. And so the highlighting here that I like to kind of just bring up is motor recovery is something like weakness, some sort of like numeric number when we're like checking someone's weakness. We can say, hey, you're actually getting better. And the quote there is that the patient gets better. But then there's also this functional recovery. You know, are they able to actually complete ADLs? Can they cook? Can they clean? Can they go about paying their bills? Can they go back to life, or are they going to need assistance from that? Does the patient does better, which I think is kind of two different ways of looking at it. But I think both are extremely important in the overall care of our stroke patients. So I have this, I made this. I'm not the most creative person, but I made this. And in the center of this diagram is exercise. So as I mentioned, most stroke rehab is all centered around exercise, exercise, exercise. But we've been continuously looking for additive things to improve the performance of stroke rehab and improve their overall rehabilitation kind of process. And they're kind of all around the board here. So we've been looking for the magic pill. Is there a medication that can show that there's actually better motor recovery, better functional outcomes? And so far, the answer is no. When I was training, I was learning about something called the FLAME trial, which was with Prozac and treating stroke-related depression. The study showed that there may have been an improvement actually in their functional standpoint. But then later there was about 3 studies showing that this indeed, they weren't able to replicate those same statistics. So now we don't think that that maybe was as accurate for that time. We look at robotics. People are wearing these exoskeletons, or they're using some sort of, they call them end effectors, which are just kind of glorified exercise equipment, essentially. Sometimes they're even programmed with different computers or different games, which can help stimulate the patient. And the data has been, you know, not pretty mixed as far as helpful. And a lot of these robotic items are expensive. And so overall, not a very drastic change where everyone is getting an exoskeleton and things of that nature. And some of this does determine on the type of deficits that they do have. We've looked at functional electrical stimulation. These are things like TENS devices where you actually put some electrodes on the muscle to try to help them from becoming atrophied, since that connection has been lost with the damage to the brain. And some of these have shown some improvements, once again, kind of depending on the type of strokes and the muscles that they're trying to look at. They also have developed some implantable devices. Specifically, they've been showing some progress with post-stroke pain. And some of these implantable devices have been helpful at kind of managing that pain. But overall, not a big player in the overall performance or improvement of the stroke population. Maybe the best so far, as far as the data showing this, is with some neuromodulation, actually. So the 2 big components that I read about were things like actually implanting a VNS. And then the other one is a transmagnetic stimulator. So the whole goal of this category is basically to augment the effects of exercise by enhancing recovery from stroke. So in the VNS, when we've kind of evaluated for that, one study showed that 3 years post-stroke, the people with VNS were twice as likely to achieve clinically meaningful gain on a type of functional motor evaluation. And I think that was a Fugel-Meyer assessment. With TMS, they looked at a meta-analysis which showed that just low frequency repetitive stimulation before an exercise did have a positive effect on motor recovery from a grip strength test, and also lower limb measured by that same functional Fugel-Meyer assessment. So kind of interesting, some kind of positive headway there, but obviously not everyone is getting VNSs dropped into them or has the capability of doing TMS. But the idea that there might be some kind of capacity for these things is you know, raising some questions and some interesting discussions. And then there's a whole bunch of, like, a whole nother caveat of things like stem cells and monoclonal antibodies and some brain computer interfaces that are kind of currently in investigation mode, and I couldn't find too much concrete data on. But my question is, one thing that's not on here is sleep. And what would this look like? what would this look like if we know these patients have obstructive sleep apnea or a large percentage of them, especially if it's on the severe category? We know that sleep is restorative. We all feel that when we're ill, when we're sick. Could treating sleep apnea allow for better rehabilitation efforts in our stroke patients? And people are looking into this. And this is where I think some of this exciting stuff kind of started sparking for me. But this study was back in actually 2011. Ryan et al. Looked at does CPAP help with these functional outcomes, and also does it help with a neurocognitive function of our stroke patients? And they did show some improvements, actually. Now, granted, the N was 44. It is a small study, but we saw improvement in some stroke-related impairment, their sleepiness score, their motor component on some functional independence measures, and their depression all improved, but they did not show any sort of neurocognitive functioning. And so it's like, okay, I'm looking at the data, what's happening now? And there actually is an undergoing study looking at this in more detail with a bigger study in the Netherlands. So this is a randomized controlled trial. I have kind of their outlook here on how the study is designed. But in our OSA patients, if we look here, they are randomizing people to 4 weeks of CPAP versus treatment as usual group. And then checking some measurements after 4 weeks, and then everyone gets CPAP after that, and then we continue to measure things as time goes on. I think this is really neat as far as investigating this and looking for some of these things. And they're also looking at some of those cognitive outcomes and hopeful that some of those might actually improve. Once again, adding to the patient's overall functional status, which leads them to having higher percentage of independence. So getting into my brain, if you're coming down with me and looking and talking, and if you will, what does all this mean? What could this mean? And I started down this whole rabbit trail, and I understand that I don't have data for this. I don't have a study objectively doing this, but I feel like this is a very exciting time for sleep medicine to get involved in a more acute fashion with this large patient population that needs help. And so I think, at least from a standpoint of research and better studies, we can do our part to investigate some of these questions. So what if OSA, if we treat it early in these stroke patients, what if it reduced the risk of them having another stroke? The risk of the second stroke occurring in a stroke patient is highest in the first 3 months, 3 months, 90 days. And as we know, most of our stroke patients are going from the acute hospital to rehab to home, and then eventually maybe getting plugged in with us. But what if it could actually reduce their risk of having a second stroke? What if treating OSA helps improve rehab outcomes, as we mentioned before? If this data did show this, how would it change our current acute management of stroke in the hospital? How would this change our stroke certifications? Would there need to be a sleep medicine person that's attached to every stroke center? Does every stroke ward need a home sleep apnea test or some sort of polysomnogram to assess for these things? I think these are some of the questions that we have the enjoyment or the excitement, or at least I do, of maybe having in the future if some of the study do kind of point in this direction. Now, Josh, hold on. This patient population can be difficult to use CPAP, and I 100% agree with you. If you can imagine someone with complete hemiparesis, even keeping the mask on that's not leaking. A lot of these patients, especially in the acute setting, are sundowning, especially as the swelling is changing from their brain. They're confused. Maybe their dominant side is weaker and they have just a hard time. Maybe they don't have a lot of caregivers able to kind of treat that. So these are considerations that we have to look at, but especially in the acute setting or the inpatient rehab setting, I think if we have good studies helping patients at least place these treatments on, then we can actually look to see, do we actually have good data showing that this exists? And actually, we have really creative people, even here at Michigan, developing really neat new tools. And so you guys might notice this as Dr. Zopf's kind of nasal pharyngeal airway that he's currently studying in the pediatric population, mainly in cerebral palsy and Down syndrome. But when I met Dr. Zopf in his clinic, the first thing I thought of was stroke. Like if I had a box of different sizes of this and I could actually throw one of these in my patient in the hospital, at least to get them to where they're able to participate with their PT, OT, their speech and swallow, their family, could that be beneficial? And once again, we don't have the data behind this, but I think we have very creative minds right now in the sleep field. And these are some of the things that we could maybe investigate going forward. So this might be a little childish or corny or whatever the proper term is, but this is what I used to do in the hospital. This is a note card. And when I was on stroke wards, every patient of mine had their own card. And this helped me keep track of all my patients. Obviously in a stroke ward, everyone's had a stroke. Is it left? Is it right? You know, things get confusing. So this helped me stay organized. And as I mentioned before, we highlight a couple things. What is the etiology of the stroke? Have we done a cardiac assessment? Has PT, OT, and speech seen them? So we know what their disposition is or what the recommendation is. Is there any ongoing acute interventions? Is there any aspiration pneumonia, any fevers, anything that we need to work up? And ultimately, what's the plan? What are they on? Are they on aspirin? Are they on Plavix? Are we managing their blood pressure? And then ultimately, it's getting them to rehab, as I mentioned. But with everything I just said, there's nothing on here with sleep. And as of right now, we don't have the data necessarily supporting that. But what if now we add some sort of OSA assessment to all of our stroke patients because of that increased risk that we do know of already, and especially if there is a helpful need in that acute setting, how would this kind of factor into my note card here as we're going on rounds and discussing each patient individually? So this is exciting to me. So in summary, stroke is common and can be life-altering. There is a bi-directional relationship with OSA and stroke, and we need better studies. We need to actually look to say, is our treatments effective at reducing the outcome of stroke in this population? And I think this is a time where we're asking a lot of these very interesting questions, and things are underway, and it's kind of a TBD kind of situation where I think in the next 5 or 10 years, we'll have more answers to this. And especially for someone like myself or some of my co-fellows, and as we're branching out into our own job sites, we may be looked at to someone to kind of help lead the way with maybe some of this new data, which, as I mentioned, I find exciting. Here's my references. And just want to say thank you to all my co-fellows and all my staff. Had a great year. I've learned a lot. I just want to say thank you.
Great job, Josh. That was fantastic. There's a question from Punitha. Post-stroke myofunctional therapy to tongue is of any value, or are studies available now? I think when you were talking about, you had that diagram with the circles about stroke therapeutics.
Yeah, I didn't specifically read about that one in particular, so I don't have the answer for that. Most of that rehab data I took from Continuum, and that one specifically wasn't discussed on there, but I can follow up with that.
I don't know if anyone else would like to unmute and ask a question.
Josh, just, I don't know, comment. When we were taking care of these patients with stroke in the unit, many a times if there is already a suspicion for sleep apnea, we get a report, right? The nurses are reporting that the oxygen levels are low in the morning. Would it be something in that sense to pay closer attention to those patients? I don't know. I'm just trying to think, as you pointed out, all the what ifs. Perhaps consider an HSAT in while they're being worked up. Sniff and other things, and maybe consider that there. Is that something that's worth you think pursuing? Because by the time they get out of rehab, it takes time. But the other thing is all these patients, I don't know. It was just a thought. Would that be something that you might recommend then? Keep an eye out while they're inpatient and keep, low threshold or maybe a home test in this setting.
Yeah, for sure. I think that's exactly what we're investigating right now. So I think there are different things out there where we look and if they're on your unit and they're dealing with, a multitude of other things, obviously it's a case by case basis. But if it's a primary stroke and there's not much else going on other than that neurologic insult that just happened, I think those investigations are currently underway and that question may be answered. That's what I was kind of speculating on, like maybe every stroke center actually has their own HSAT machine that they have, and they kind of and they send to different patients around the ward. I can kind of think of a whole bunch of different ways that might look. But I think to answer your question, potentially yes.
Yeah, thank you. And the other thing is, with these patients with their aspiration risk, even if they do have sleep apnea, I would be so hesitant to put them on like any kind of full face mask to treat them with positive pressure. That'll just it's very it's concerning right there with the aspiration risk. Yeah, maybe.
Yep.
Close clinical follow-up. Thanks, Josh. This was great.
Thank you.
Hey, Josh, great overview. Great talk. Thanks for going through all that. I'm wondering after you digested all that literature, whether you have an opinion or thoughts about the causality. And you noted that correctly that something like 3/4 of the patients of patients post-stroke have sleep apnea, and obstructive sleep apnea in most cases, with small proportion are central. And I had the feeling in your talk, like you're thinking, okay, well, it's the, well, actually, I'm not sure. Let me ask, do you think it's the sleep apnea that came out from the stroke more, or do you think that it's the sleep apnea that pre-existed and caused the stroke, or both?
Yeah.
Or what do you think?
Yeah, I would guess it was more both. I think if we look back on these patients, the same cardiovascular risk factors are for stroke as for your heart, and a lot of them are obese and have hypertension and things like that already. So maybe that's putting them at risk already for sleep apnea before the stroke. But I think especially in that latest meta-analysis, it does seem like that there might be some some details of obstructive sleep apnea related to the insult. So I think it's a mixture of both.
It's hard to know. It's an unfair question, but I was interested to what you think.
Yeah.
One thing that I keep in my mind is that the incidence of OSA after stroke versus TIA is about the same.
Right.
So TIA by definition doesn't leave you with deficits.
Right.
So
that's a great point. Yeah. So there was no insult there to cause the OSA or worsen the OSA in those patients, is what you're saying.
Yeah, exactly. So that makes me think that it's not the stroke causing sleep apnea as often. But yeah, it's hard to know. And I think you summarized the state of the literature very well, where this is what we saw when we started Sleep Smart. That it was just a lot of very suggestive, even not only cross-sectional, but longitudinal cohort level data, suggesting that there might be a tendency for sleep apnea to raise your risk of stroke and make it harder for you to recover. And it makes sense, right? If you're having an ischemic prone brain, or you have an ischemic penumbra after your stroke, who wants to hold their breath and desat to 70 multiple times a night?
Exactly.
But it is hard to study, and yeah, and the points you raised about the past cardiovascular trials are very well taken. Although I'll just say that it's I don't dismiss the trials that come out with the low adherence, because if your question is a clinical question, should I give my post-stroke patient treatment, look for their sleep apnea and treat it? If it's a practical question of that, like that, of importance to the patient, those trials still tell you the answer in essence, because if they tell you that, well, you can't get your patients to use CPAP, it's telling you the answer. Now,
Right.
I
What
think
good is it?
what you're yearning for, I think, and what I'm yearning for too, is the biological question. Okay, sort of the because the as treated analysis, not the intent to treat, but the as treated analyses from some of these trials have suggested, like you said, that there is benefit to identifying and treating sleep apnea. So, there's the biology question where we're really suspicious and if not proven. And then there's the clinical question. So, yeah, what your generation should do, and you're right, you're going to be asked this more and more, but is like you were saying, figure out either how to get people adherent or figure out a self-sustaining nasopharyngeal airway or something that's going to
Exactly.
solve this. I will say that Devin has been right where you are, Devin Brown, in terms of that conclusion for years now. So she has done some interesting things. She's led, I've helped with some of them, but she even tried nasal strips, as I recall. She's at one point there was a question of what about the positionality? So, even if it's possible that you could help some of these post-stroke patients just by keeping them off their back. So publish some on that, but yeah, we need a better solution or a better alternative to CPAP in general, but for some specific medical populations like this, we may need even more,
Yeah, completely agree.
Yeah.
Completely agree. Thank you.
I would like to add one more thing. When we do the clinical prediction rules for risk of, TIA to, stroke predictions, we never use, we use the hypertension, age, and all diabetes and other things, but we never use sleep apnea risk as one of the, prediction rule. ABCD score that we use to predict, the TIA patient to have a risk of stroke. We never use, sleep apnea. Nothing is there in that rule.
Yeah, and maybe it should, right? Like, I think we at least have enough data, even as Dr. Chervin was saying, that these people are still at risk, whether it came before their event or after. But that should be incorporated, I think, to all patients that have vascular comorbidities in general. Well, thank you all.
Great. I don't see any more hands up or any other items in the chat. So great job. Thank you, Josh.
Thank you. Have a
Great
good day,
job,
everyone.
Josh.